So this is a talk about the start. We'll start with minimally invasive surgery basics. Minimally invasive surgery really describes a number of areas, including arthroscopy, but today I'm going to concentrate more on a minor, sorry, I've got a message, sorry. I'm going to concentrate more on the particular technique using the minimally invasive burr and X-ray. So I have been in foot and ankle surgery practice for 20 years. I work in private practice in Melbourne, and I did run a fellowship for many years, and I have been, was lucky enough to be the inaugural chairman of the foot and ankle section of the Asia Pacific Orthopedic Association. And this picture is some people you know, Dr. Kumar, Dr. Rajiv Shah, and other members of our committee. And I would encourage you all to join this foot and ankle section if you can. So when we look at the minimally invasive surgery, this is a technique which I first started to learn approximately, 9 years ago now, now we're into 21. So I went to a course run by David Redfern and Joel Benoit, who are still very much the experts in the area. So this is using the small burr, which you can see on the picture, with a power unit that is used to cut bone, and the technique allows this to be done quite safely. However, it took quite a while after going to the course for me to start doing some surgery, as I wanted to evaluate it. And so it was 3 years later before we started using in any real numbers. And then I started doing the bunion surgery, minimally invasive, 2016. And then after doing some more cases, I went back over to Europe in 2018 to Olivier Lafenetre, who is a very, very good surgeon in France, in Paris, and David Redfern again in 2019. But I would say that I virtually converted most of my practice over to minimally invasive from 2018. So this list here is a list of cases that I no longer do via open surgery. And this was normal part of my practice until we started developing minimally invasive techniques. So this includes virtually, for me, virtually all forefoot surgery. And then there are some hindfoot surgery cases and midfoot, including calcaneal osteotomy and some midfoot colectomy, arthritis. So the reason being is that there are a number of advantages. So really with minimally invasive techniques, the wound problems and infection problems that seem to be an issue with foot and ankle surgery seems to fade away dramatically. The patient also spends less time in hospital because they have minimal pain and they're not required to elevate their foot as much. They have far less swelling and they get back to normal life much quicker. But I will point out that the biology of bone healing and body healing is still the same. And so there is, for the final result, it still takes quite a while. And this is a picture of myself giving some talks in London. And Chris was the president of the British Society, and Mark Glazebrook, who's president of the Canadian Foot and Ankle Society. So the technology for minimally invasive surgery has been adapted from dentistry. So if you imagine the little machine that the dentist uses to do the filling, it's very similar, in fact, made in the same factory. And there are two options with the burr. One is a high speed burr with that is you need to use irrigation with that technique. There is also a low speed, high torque technique without irrigation. And that's the technique that I prefer. The burr can go in forward and reverse, but really you're just going forward. So safety is very important with any surgical technique, and minimally invasive surgery can be quite risky. So you need to know what you're doing and be very safe. So the things that you need to be important of, the burr is run by a foot pedal, and you need to ensure that you don't accidentally turn the foot pedal on when it is not, when you're not using it, because your feet can move up and down. And particularly if it turns fast, it can damage either the patient or the drapes or the assistants. If you're not using irrigation correctly, you can overheat the bone, which may cause necrosis or nerve and tendon damage. If you sometimes can accidentally press the reverse button and you use the burr, but because it's spinning so fast, you can't tell whether it's going forward or back. But it's much harder to cut the bone in reverse, and you tend to overheat the bone. So you have to be very cautious with that. You need to clear some space under the operating table, because you're using your feet a lot to use both the X-ray machine and the pedal of the burr. And if there's a lot of drapes there, you end up usually kicking things and may cause some problems. And perhaps the most important you need to ensure is that you protect yourself from radiation, because this is a technique where you use a lot of X-ray, and if you can't use a low intensity machine like a mini C-arm, you really need to be protected and take care of yourself. But I think just as important as a burr is the mini radiology machine, as that you are going to take a lot of X-rays. So if you can get one of these machines, you'll be much safer. So when we look at the starting cases for the surgery that you're going to do, if you try some, I would recommend using it on patients where the skin risk is high, but the bone surgery is straightforward. So these are cases where if you do them with traditional open surgery, you have higher risk with infection and wound problems. So these are good cases for minimally invasive. So conversely, you're sort of better off starting with more higher risk cases from a skin point of view than with other techniques that you might be learning. So a good case to start would be removing a bone spur from a diabetic Charcot foot, or correcting a bunion, or taking the bunion off on an elderly patient, which is you can do far more safely minimally invasively than with open surgery. When you position the patient for this type of surgery, it's best to put the patient over the end of the bed, because you need to swing the X-ray machine in and out to get appropriate imaging. And it's much easier to do that with the patient over the bed. Some on the right here, we have a bunion case where we've positioned the foot with supports so we can get in and do it correctly. And this is an image of a case. So it's at the end of the bed. You can see there's good clearance under the table, and I use these little clips to clip the drapes, and we have the X-ray machine. These are the type of burrs that we use. The top one on the left is a 2 millimeter called a Shannon burr, which is a cutting burr. So that will cut through the bone, whereas the one on the bottom right is a wedge burr, and that is used to grind the edges of bone. So to remove a spur, or excuse me, So if you need to remove osteophytes or spurs, a wedge burr is appropriate. Other devices are used depending on the situation. The thing that looks like a can opener is for hallux valgus surgery, shifting the bone. The bottom is a beaver blade, which is popular. I just tend to use a normal 15 blade, but the beaver blade is very popular. And the others are periosteal elevators and rasps. When you make a small incision, you need to lift the periosteum and protect the soft tissue, so an elevator is important. And if you've shaved a lot of bone, you need to remove that from under the skin. And so a rasp and irrigation is important. So we'll go through some various cases. This first one is a calcaneal osteotomy. You can see here that the osteotomy is performed in a chevron shape, and that is just through a small incision, one 1 centimeter incision in the center of the chevron. The patient is in the lateral position with the image intensifier, and you mark the skin position and get the lines for your cut. And I use a 3 millimeter burr, and we start in the central position, and you start making some cuts, and then check your position again on the image intensifier. So this can be done. You can do both a medial translation and a lateral translation, and you use the shifting tool that you use for the bunion. You can shift the bone quite nicely. Usually steady it with a K-wire and insert the screws for fixation. When I first started doing calcaneal osteotomy many years ago, we used an L-shaped incision and we made cuts, and the wounds were terrible. We slowly got better with smaller wounds, but this really means that it's a home run, and you virtually never ever have a wound problem or infection. So it's a wonderful advance. One of the another case which is very useful is for bunionette correction. Before MIS surgery, I didn't really ever do internal fixation for bunionette correction, so it wasn't a big leap to do a similar operation via minimally invasive surgery. And you can see just a very small incision here. And we've done an osteotomy with some translation and a little bit of elevation. And it's a very quick and straightforward procedure. So that's not a bad case to start with if you are interested in, if you have a patient, because it takes a very short amount of time. One of the big areas which is critical and I use all the time is correction of claw toes and toe deformities. Any toe deformity you can imagine can be corrected by minimally invasive surgery. You don't need to remove any callosities because they all fall off in the end. There are some schools which do not use internal fixation, but I do prefer a temporary K-wire fixation, which is very good in my practice. So with this technique, I can show you a bit later, but we release the plantar plate using a 19 gauge needle, and then we make some osteotomies, one usually in the middle of the proximal phalanx, and sometimes in the middle of the middle phalanx for a severe deformity. And then the toe can be repositioned and internally fixed with the wire. It's very straightforward. This is a case where we've done K-wire for 2 toes and also use the wire to assist with the bunionette as well. So this case, very severe deformity with very bad toes, both the great toe and the lesser toes. And we've been able to correct all of the toes, including interphalangeal joint arthritis of the great toe, performed via MIS surgery. I did do an open extender hallucis longus lengthening though as well, but the lesser toes all were pretty good. The other area which is useful is for subluxed or dislocated toes and plantar plate tears, metatarsalgias, where we use a distal metatarsal osteotomy, where we need to elevate and shorten a metatarsal to allow for correction. The other area which I find very useful is for hallux rigidus. For the early cases, we use a colectomy, which can be done MIS, and also a Moberg osteotomy, which we can also do using MIS techniques. And this has really revolutionized the treatment of early hallux rigidus in my practice. The other area which I use in forefoot surgery is first MTP arthritis. So this traditionally before this we used plates, and the plates were quite okay, but now it's just done through a small incision where we remove the osteophytes, debride the joint, and internally fix. Hallux rigidus is pretty common in Australia. I'm not sure whether it's a common disorder in India, but it is a big problem for many people here. Oh, where did we go? Oh, I think that's it for the basic now. So would you like to stop and do some questions or something at the moment?
Yeah, I guess so. Dr. Raja, sir, what do you think?
Yeah. Yeah, you can go for basic talks now, then you can go into advanced. So that people will understand better. Advance? Yeah, you can stop for about 5 minutes of question answer session and then go ahead. Or okay. If you've got more slides, you can go ahead, because if suppose they don't understand anything. Because this is a new topic, people are getting used to. I've been operating so, Mark, MIS for last 20 years.
Can I ask a question?
Yeah.
Can I ask a question?
Yeah.
Yeah.
Mark, can I ask a question? Yeah. What I want to ask you is, what happens to the bone debris? What happens to the bone debris that you create when you have cut the bone? Do you sort of squeeze it out, or you just leave it all inside?
You need to remove the debris. So you need to spend a fair bit of time, both with the irrigation. So I have a 20 ml syringe with a small needle, which we irrigate, and a lot of it will just come out. And then you use the rasp to remove more. And then you keep doing that until you're happy that it's been cleared. So yeah, if you don't clear it, you can get a heterotopic ossification, which can be annoying for the patient, and you have to go and take it out, because it can coalesce and become hard, just like any bone, if you don't do it properly. So you do need to remove the bone.
Thank you for that.
Hi, can I add a word there? The remaining bone that is left in the situ becomes a bone graft, additional bone graft, because it is a thick paste.
Yes, if you're doing arthritis, you can leave some bone there.
It becomes the basic bone graft, because the bone that is mashed out is mixed with blood and becomes really thick paste. So it becomes a bone graft when you're doing hallux valgus or first MTP arthrodosis. It acts as an additional bone graft.
Yes.
Yeah, you can take it out and put it back in again in somewhere else as a graft if you wish.
Is there.
Can I ask a question?
Welcome. Yes, sir, please.
Yeah. Hi, Mark. Very good evening, and
hello,
welcome to Indian Foot and Ankle Society. Right. Yeah, fantastic going as usual. Now, 2-3 questions. What are the qualities which a surgeon who is doing MIS surgery like this requires to possess? That's one. Second, what is the learning curve for these surgeries? So there's two things, if you can elaborate, it would be helpful for our members.
Yes. Well, I think the person doing the surgery needs to have perhaps a little bit of three-dimensional awareness. So you need to be able to perform surgery with an X-ray machine without actually imaging everything internally or being able to look at everything inside. So it does require a certain an element of training, and I would encourage people to either visit a center or do a course, and really it's a sort of it's a movement rather than you're doing the same operations but doing them differently. But I would suggest starting with very, very basic procedures and just evaluating them for a long period of time before you progress to more complicated surgery. So to me, something like a removal of a bone osteophyte or a spur is a good way. Like a diabetic patient with a bump from their Charcot is a really good thing to do, or an osteophyte for arthritis, and then maybe bunionette, and then I think if that's going well, you might and you have a calcaneal osteotomy, that's actually not too bad to do. So I would suggest start slowly and develop some confidence.
Oh, thank you. And what do you do to the periosteum?
Well, the periosteum you generally leave intact. You do lift it in. You do use a periosteal elevator and lift the periosteum adjacent to where you're making your cut. But the remainder of the periosteum proximally distally, you leave intact, and that is a good thing because there's less disruption of blood supply, which allows for rapid healing.
Thank you, Mark. Thank you.
Can I add a word?
Please.
Yeah, all these procedures in forefoot surgery are mostly intraperiosteal procedures. So you maintain the periosteum for the blood supply as well as a thick sleeve so that the bone doesn't get displaced much when you do a intraperiosteal osteotomy. You make an incision in the soft tissue, then the incision goes deep to the periosteum, then you use your small elevator and lift the periosteum and do your osteotomy there. So this is how the procedure goes.
Correct.
Yeah. So you're actually, if you can avoid cutting through the periosteum that you've elevated, that's the best. Yes. So you just want to cut the bone, but not keep cutting and damaging other things.
Other soft tissues. That is why when I do a forefoot surgery, I normally use a 18 gauge or a 16 gauge needle up to the bone, then use that as an elevator and take a sleeve inside. Then I use the MIS elevator and go around the bone on two sides, above and below.
Yes, that's correct. You need to go above and below, definitely. Excellent. All right. Well, maybe I'll go to a more advanced talk.
Yeah.
And
before that, one question, as everybody wants to know, what is the RPM, rate per minute? See, what is the RPM you want them to do it? Because everybody is interested in knowing what do you talk about low speed, high torque. Because we use low speed, high torque so that we need not do a continuous irrigation. So preferably,
the setting comes with the machine. So this and the high torque is actually set by the nose cone, which is a different nose cone to the burr than the normal one, and that has a 4-to-1 reduction. And I think the standard speed is about 4,000, so it goes around 1,000, but it has a higher torque. And I'd have to refer to the company in the brochure, but I wasn't able to get torque figures from the
no company gives you torque figures. It varies from machine to machine. And normally we use about 2:1 reduction or 4:1 reduction depending on the hand piece and the hand motor. And preferably you set about 2:1, you set 10,000 at RPM, and then it works out to 5,000.
Yeah, that's
when
right.
you are using for an osteotomy, it can be up to 8,000 to 10,000 max. When you are doing a reduction, it has to be low because continuously the motor will be going on. So there you reduce the RPM. And one more point.
So if you use the normal sort of round burrs and things that we've traditionally used, they go around 20 to 30,000. So it's much slower than a standard burr that you would use. So, so you can use a normal burr, but only for very small bones. And so you turn the burr way down low speed, and you can use it maybe for a toe or something. But if you need to do a real operation, you maybe a metatarsal or midfoot, you need the special equipment. Yeah.
Yeah, Mr. Mark, if you allow me.
Yes.
There are very few, there are quite a few interesting questions in the chat box. Can I go ahead and answer them?
Yes, please. Ask. That's what we're here for.
Right. A very senior and respected foot and ankle surgeon from Delhi, Mr. Kamal Dureja, Dr. Kamal Dureja. He has asked a question. And the question is, how is the equipment different from that used by ENT surgeons?
Okay.
Well, I don't know what the ENT surgeons use in that respect, but it would be similar. But I know that they might use a much higher speed.
No. Can I?
Yeah, please, sir.
Please.
The ENT burrs are only reduction burrs. They don't have anything called Shannon burrs, which are cutting burrs. In orthopedics, we have the Shannon burrs, which are called as cutting burrs, which have 2.5 mm dia and 4 mm. And there are Shannon reduction burrs, and you have Isham burrs, which are for cutting, and wedge burrs for reduction, and they are called Christian burrs. There are 3 companies which manufacture this and supply it. One is the commonest company now UK and Europe is doing, and Australia is doing, is Wright Medical. They are called as Kativa burrs. And next company internationally is the Vilex, VILEX. They are the international burr company. And next one is a Japanese company called Osada. They have the drills with 2:1 reduction, and they have the burrs. And it is Central America where they manufacture all these burrs. So in ENT, they are only reduction burrs where they use it for your mastoid surgeries. And neurosurgery also has burrs. They are also use them for reduction. They don't have anything called cutting burrs. You can use the ENT burrs and see. Only you can try and do a bunionectomy with them, and those burrs are not laser cut burrs for cutting. They are only reduction burrs. Maybe you can try doing a bunionectomy with them. But the problem is they do the surgery not intraperiosteally. For your kind information, they open up the mastoid and use their burrs. We are doing the procedure as the skin and periosteum as a sleeve. So if heat is generated, then you will have skin necrosis and soft tissue necrosis. Whereas ENT surgeons open the area and do with their burrs, where if heat is generated, they are not worried. This is the difference between ENT and the orthopedic or podiatric burrs.
Wonderful, wonderful, Raja sir. Let me tell you something. I in 2019 May went and did a fellowship with Mr. Mark and learned quite a few tricks from here. But when I came back to India, I really didn't know from where to obtain the instruments. It's really nice that you are telling me this. In fact, there's a question from none other than Dr. Rajiv Shah sir, and he's asking, Which company supplies such an equipment?
Right Medical. Rajiv sir, Rajiv Bhai knows everything. I have given him information. It is Right Medical. Right Medical is not in India. That is the problem we are facing.
Yeah, that's
because
yeah.
Right Medical is not in India, and you don't get the long bursts where you use it for the calcaneum. You'll have to get it from UK, Australia, or US. We don't have the long bursts. You get the short bursts, but not the long bursts. In long bursts for calcaneal osteotomy, you need the 6 inches. I think it is the
you need a long
burst to do the calcaneal osteotomy, and you don't get those bursts. Actually, I have designed a sleeve for the calcaneal osteotomy, and for pushing the osteotomy and holding the wire there, I've made a instrument there. So I've been doing it for 15 years now.
Wonderful, sir. Wonderful.
I was trained by, I think Mark knows Mariano Di Prado in Spain.
Yeah. Yes,
I was trained by Mariano and Isham of US.
Yeah.
In 2005, I was in Spain and I got trained, and then I got trained in 2008 by Baruch.
Wonderful.
Yeah.
Wonderful. So, I'm sure Rajiv sir must be asking that question, putting this question for the benefit of novices such as me.
Yes, for everybody. Actually, in India, we are lacking the burrs and the drills, because either you'll have to go for Smith & Nephew, or you'll have to go for a striker where the initial investment is too high for break even, and service backup and all these things are very difficult. So if Right Medical comes in, you get burrs at cheaper cost. And Dr. Rajiv sir, to my knowledge, he's been working on this for last 10 years. He's been asking other companies to come out with these burrs and motors, and he's been insisting in every EFAS conference for youngsters to learn the technique and implement. Yes, he's been telling me for a very long time to do that, because none of the companies are here who provide the small motors. The problem is you don't get the handpiece and you don't get the motor. That is the only problem we have here.
Absolutely, absolutely.
The more surgeons start doing it, then we'll get everything here.
Absolutely. That's what Rajiv sir is writing, that these questions are meant for making youngsters learn.
Yes, and yes. And he's been telling for a very long time. Rajiv sir has been insisting on this for a very long time. He wanted all the youngsters to learn the technique and do it. As more people start doing, you get inventories in India.
Absolutely. So one more question is there from a young surgeon, Dr. Gyan. Gyan is asking, sir, as a fresher to foot and ankle surgery, what precautions should I take while doing this osteotomy? I mean, the osteotomy by minimum invasive method. So I think his question has already been answered, but maybe Mr. Mark can answer that again, up to points maybe.
So what precautions to take with osteotomy, is that?
Yes, while doing by MIS method.
Well, the main precautions that you need to, obviously, there's general precautions for MIS surgery, but the main thing is to ensure that you protect the soft tissues around the osteotomy site, that you protect the periosteum, and that also that you do the osteotomy in a correct position. Obviously, that seems an easy thing to say, but you're doing the surgery under X-ray. You need to have the X-ray.
Yes, some problem with the voice.
No, his mic has gone to mute.
So we can't hear you.
Mr. Mark, sir, we can't hear you. Mr. Mark, we can't hear you.
His mic has gone into mute, boss.
Okay, Mr. Mark. Oh yes, asked to unmute.
All right, I'm back again.
Yes. Yeah. You can go ahead.
So with the surgery, you just need to protect the periosteum, and you need to ensure that the osteotomy is performed in the correct location and alignment, because you have to be exacting with the position so that you don't shorten or elevation or angle the osteotomy incorrectly. Yeah,
there's another question from Dr. Anupam Srivastava, Varanasi. and is asking, is it safe for a sports person? Maybe he's asking your experience with the sports person of this surgery. Mr. Mark.
Well, I think it is an ideal, anything that's minimally invasive is advantageous to a sports person.
Yes.
But I would say that these cases, the minimally invasive surgery for sports people mainly is arthroscopy or endoscopic techniques, because these type of surgeries are more for degenerative and more elderly people than the sports person.
Right.
Yeah, because unless if you have to do a DMMO or osteotomy, that's no problem. But most of the sports people I treat, they need arthroscopies and endoscopic procedures.
Right. We have our another panelist, Mr. Dr. Abhishek Kinney. Hi, Dr. Kinney, are you there?
Yeah, I'm there, Shantanu.
Oh, wonderful. So maybe we could have your comments on the first presentation that Mr. Mark made. What have been your experiences of doing something arthroscopically or minimum invasive foot and ankle surgery?
So I think we face the hurdle of not having correct equipment. I've tried a couple of times with dental burrs to get my Hageland's bump off when I'm doing an endoscopic or assisted things, but I think having the correct instruments is of paramount importance to make sure that this happens.
Right.
I think it's a bit of a challenge for us to kind of do it without the correct instruments. And I think my comment, like when I was in UK and I was doing it, even when I was in France and doing it with Pierre Baruch and all, I think getting the translation looks easier from outside, but when you're doing it intraoperatively, getting that correct translation for your osteotomy, even if it's a scarf or even if it's for a calcaneal osteotomy, it is not that easy.
Absolutely.
So I think sometimes while I was learning it, maybe it was my learning curve, I have incised the periosteum until which I have not got my translation correct. So I think it's easier to look at and say this is MIS, but while doing it, I think it has a steeper learning curve.
Okay,
Right.
I'll add in a word. See, selection of case is very, very important. If you choose a case in earlier days with severe deformity, then as you said, displacement will be little difficult because your soft tissue structures are intact, your periosteum is intact, and you need special device to push the osteotomy and hold it. So selection of cases with moderate deformity or simple deformity to do in MIS earlier stages is better.
Right. So that is a wonderful comment. Mr. Mark, can we now go forward and learn some techniques and some specific surgery, some videos from you, sir? Would you find, Dr. Raja?
Yeah, please go ahead.
Yes, sir.
Let me share my screen and I'll find something for you.
Right, sir.